Well, I think that things may change. We're expecting new outcomes data from the Odyssey outcomes trial that's just ending, and so the results are going to be available next year. And we have one trial now, Fourier, which showed a benefit. The trial was very short, though. The follow-up period averaged only 2.2 years, and so the full benefit probably was not realized in the patients who participated in that trial. With Odyssey outcomes, the follow-up time will be longer. I think we'll see more evidence of benefit. And then the conversation becomes one where the question is really, who are the appropriate patients in whom the healthcare system can afford to provide this very effective treatment? I'm saying that now with the assumption that Odyssey outcomes will produce the expected results. We would be very surprised if that were not the case, because we have so much evidence now that lowering atherogenic cholesterol is effective for reducing event risk. And it's not just the amount of lowering, it's how long it stays low. And so because of that, we expect favorable results with Odyssey outcomes. And if that's the case, then I think there's going to be a much stronger argument for treating more people with PCSK9 inhibitors. And then it becomes a trade-off between benefit versus cost. I think they're both important because in the end, the economics is the study of limited resources with alternative applications. And so if we're spending money on PCSK9 inhibitors, there may not be money available to spend on other things. So in patients who have high enough risk to justify the treatment, I think it's going to make very good sense. And ultimately, payers and as a society, we have to figure out what are the thresholds that we're going to consider when deciding what makes sense economically and what doesn't make sense. So these are very complicated issues, and we don't have great systems right now for dealing with those. I think the CVS approach is very helpful because I know in many cases that people are prescribed a medication that's very expensive. Their physician really has no idea what the cost is, and the patient doesn't know that there is an alternative that might be less expensive. And so as one example, recently I heard of a patient who was prescribed a medication that was something along the lines of $600 a month for the medication. And it was a combination of two things, but if each of the things were taken individually, the price would have been about 1/10 of that. And so, these types of things do occur. Physicians don't know what the costs are when they're writing the prescription often, and patients don't know what the costs are when their physician is recommending something. And so there really isn't that opportunity to have a discussion about, is there an alternative that might be less expensive? And so like many places in our healthcare system, we don't have good systems to manage expenses because we are ultimately going to have to manage expense versus benefit, and the current system doesn't lend itself very well to doing that.